दोबारा कर रहे हैं, अब बताना मुझे। I'm audible now?
Yes, sir.
Okay. So I'll start in a second.
Yes.
So I think all of you know that an ulcer is basically a break in the epithelium, which is of a sufficient diameter and of a sufficient depth. So if we talk about peptic ulcer disease, we take it as a break in the gastrointestinal mucosa, which is exposed to acid and pepsin, and it penetrates up to the muscularis mucosa. The peptic ulcers mainly, the main sites of peptic ulcers are either duodenum or the stomach. So, in contrast, an erosion is a break in the gastrointestinal mucosa which is less than 5 mm in diameter, and it does not penetrate muscularis mucosa. And it can occur also in acid secreting and non-acid secreting mucosa, and it heals rapidly as compared to an ulcer. So basically, what are the common sites in which peptic ulcers are present? So, according to the definition, they can occur in any area of GIT where either acid or pepsin are present. The commonest sites are duodenum, especially the first part, which we also call as duodenal bulb. So, if we look at this diagram, so this is the pylorus, and from the pylorus up till the this first part of duodenum, which is mainly the horizontal part, it is also known as the duodenal bulb, and it is the most common site for the peptic ulcer diseases. The other site is the stomach, and the peptic ulcers are more common towards the lesser curve as compared to the greater curve. And the lower end of esophagus can also develop peptic ulcer because due to the reflux, it is also exposed to the acid as well as the pepsin. The other sites which can also develop peptic ulcers are the gastrojejunal anastomosis and sometimes in the Meckel's diverticulum, because Meckel's diverticulum also sometimes has gastric mucosa. So what are the clinical features of the gastric ulcer and duodenal ulcer? So these on the left hand side are the features of the gastric ulcer, and on the right are the duodenal ulcer. So they have although the symptoms are non-specific, you cannot diagnose an ulcer disease just based on the symptoms. But the gastric ulcer and duodenal ulcers among themselves have a definite set of symptoms. For example, in the gastric ulcer, the pain occurs after eating, while in the duodenal ulcer, the pain gets relieved after eating. It is a very important point in differentiating between these two types of ulcers. Besides, the vomiting is more common in the patients with the gastric ulcer, and therefore due to both these factors, that is pain and vomiting after eating, they are a bit afraid to it and they lose weight. Whereas the duodenal ulcer, the pain is classically described as a hunger pain, and which occurs late after 3 to 4 hours after meals, and due to which it awakes patients from the sleep, and patient usually have less vomiting and good appetite, and therefore there is no weight loss. Now moving to the next slide. आ रहा होगा, अभी आ रहा होगा, फिर मैंने वैसे
हाँ,
किया,
अब आ गया।
पता नहीं क्या प्रॉब्लम है। चलो, ओके ओके। So this control is the control panel visible now? Sure. So basically, biological factors which are described for the peptic ulcer diseases are the H. pylori, NSAIDs, smoking, and some genetic factors. And there is a controversial role for diet, alcohol, and stress. So basically, if you think about the ulcers can be developed in whole of the GI tract from esophagus up till the anal canal. So so when we talk about peptic ulcers, so peptic ulcers are basically the ulcers which occur at the site at the sites which are exposed to either acid or pepsin secretion. So the increased acid secretion is basically has an important role in the development of a peptic ulcer. So all the ulcers, you must also remember that these sites, that is the stomach as well as duodenum, can have ulcers due to the other reasons also. So when the pathophysiology of an ulcer is due to an increased acid secretion or due to an imbalance between the ulcerogenic factors and the protective factors, then we call it as a peptic ulcer, because a malignant ulcer is also an ulcer, but we don't call it a peptic ulcer. Peptic ulcer is when the pathophysiology is mainly the increased acid secretion. So or you can say it is like an imbalance between the epithelial protective factors and the epithelial damaging factors. So like NSAIDs, smoking, and there are some genetic roles. And there is, as I said, there is a doubtful role of diet, alcohol, and psychological stress. Mhm. I'm not able to change the slide. Just a second. I'll tell in a brief about the regulation of gastric acid secretion. So this is the parietal cell. So the gastric glands mainly have the chief cells and the parietal cells. Chief cells secrete the enzymes. They have the zymogens and they secrete the pepsin. And the parietal cell secretes the acid, that is the HCl, hydrochloric acid. So for the hydrochloric, there are so the hydrochloric acid is basically secreted by the parietal cell due to the activity of the proton pump, that is a hydrogen potassium ATPase. It is just like sodium pump uh, which you also read about in the nephrology. So the potassium pump, it basically leads to the secretion of the potassium ions in the canaliculus against the concentration gradient, and the chloride ion, it gets secreted passively along with the potassium along with the hydrogen ions, and thus the hydrochloric acid is released in this canaliculus and from it into the lumen. So various factors which increases the activity of the proton pump are the acetylcholine, that is through the parasympathetic system through the vagus nerve. The histamine is released by enterochromaffin-like cells and also by the gastrin. So whereas the somatostatin, it decreases the activity of the proton pump by directly inhibiting them and by inhibiting the ECL cells. So any factor which can lead to an increase in any of these functions like gastrin uh, and the histamine can lead to the can lead to the increased acid secretions and ulcer. So one example of this thing is like Zollinger-Ellison syndrome, in which there are gastrinomas in the duodenum. The gastrinomas lead to increased secretion of gastrin. The increased gastrin leads to activation of the proton pump, which leads to increased acid secretion into the lumen and formation of the ulcers. So we talk about what is the pathogenesis of the peptic ulcer. As I already told you that the peptic ulcers are basically arise due to an interplay between the defensive factors and the aggressive factors. So which ultimately lead to the damage of the epithelial layer of the stomach or the lower esophagus or the first part of duodenum. So the various defensive factors which protect the gastric mucosa are the mucus layer or the bicarbonate. Mucus layer contains the bicarbonate, and they also contains various mucins, which are specialized proteins which protects the gastric layer which protects the gastric layer from getting disintegrated and prevents the formation of ulcer. The other is the blood flow, which removes the various toxins and the acid and pepsin from the site and help in the and maintain a continuous epithelial layer. The other is the cell renewal and restitutions, prostaglandins and phospholipids. Whereas the aggressive factors are H. pylori, drugs, acid and pepsin, and bile salts. All of these have different all of these damage the epithelial layer, and we will talk a little bit about the H. pylori and drug and NSAIDs about their mechanism. So again, this is an example. This is a diagram of showing the gastroduodenal mucosal defense. So basically, this is the mucus layer, and it contains bicarb, which neutralizes the hydrogen ion, and thus it prevents the damage to the epithelial layer from the acid. Similarly, the mucus also contains many proteins which forms a thick gel-like structure, and through which pepsin cannot penetrate and harm the gastric epithelial cells. The prostaglandins, the prostaglandins and the increased and the blood flow, through the capillaries, it also reduces the exposure of the gastric epithelial layer to any toxins which may be present. Similarly, the epithelial layer itself has the capacity to regenerate and restitute, and which also so if there is some damage, it can heal itself, and it forms the second layer of the defense after the proepithelial layer. And similarly, subepithelial layer consists of microcirculation, and it removes the toxic materials. So we'll talk a little bit about the H. pylori in detail. So earlier the peptic ulcers were usually thought to be caused by stress or by the diet, alcohol, but the Marshall and Warren, they in the 1970s, they found that the H. pylori is the main cause for the gastric ulcers, for which they won the Nobel Prize in 2005. So when they first discovered that the H. pylori is mainly the cause for the gastric ulcer, so there was a lot of skepticism around it. So Warren, he himself drank a culture of the H. pylori, and after that he developed gastritis and ulcer, and thus he established that the gastric ulcer is caused by the bacterium H. pylori. H. pylori is a gram-negative spiral bacillus, and it has a tuft of flagella at one end, and it is highly mobile. So it is more prevalent in the developing countries as compared to the developed, and it also is a risk factor for development of gastric carcinoma, and is described as a class 1 carcinogen by the WHO. So it is the major etiological factor for peptic ulcer disease, and it is found in 50 to 70% patients of the duodenal ulcers, 30 to 60% patients of the gastric ulcers, and in almost all patients of chronic active gastritis. And as per an estimate, the 60 to 70% of world's population is infested, but only 15% of patients who are infected with H. pylori will develop any symptoms. Okay. So although a vast population of world is infected with the H. pylori, but only a proportion of them, that is around 1/6 of them, develop any disease. So now I'll just briefly touch about the about the NSAID-induced ulcers. So NSAID-induced ulcers are mainly because it can either be due to the direct toxicity, that is the NSAIDs, they get trapped in the mucosa and cause a direct toxicity leading to the formation of an ulcer, or they can lead to a stasis in the microcirculation and contribute to the and leading to ischemia, and the ischemic injury contribute to the formation of the ulcers. Or the other thing is that the prostaglandin, as we know that the prostaglandin are the protective uh, is a protective defensive mechanism for the for the gastric epithelium. So as NSAIDs, they inhibit the prostaglandin synthesis. They lead to increase in acid secretion and decrease mucin and bicarbonate secretion, and which lead to the ulcer formation. So H. pylori and NSAIDs have a synergistic role in the development of peptic ulcer disease. So if we eradicate the H. pylori, it reduces the risk of peptic ulcer in the new NSAID users. And but however, in the chronic NSAID users, the maintenance doses of proton pump inhibitors are more effective than eradication of H. pylori in preventing the ulcers. So if a patient who is on chronic NSAIDs use, like for a joint pain, for an arthritis, so it is advisable to give them a maintenance dose of proton pump inhibitors to prevent the development of peptic ulcers. So just to tell you about the risk of bleeding, so if only NSAIDs are used, there is 4.8 times increased chances of bleeding from a peptic ulcer. And if H. pylori is present, then 1.8 times, and if both are present, then there is 6 times increased chances of development of bleeding in a peptic ulcer. So H. pylori basically it transmits through fecal-oral route, and the prevalence of infection increases with the age. So how does H. pylori causes an gastric ulcers? Because it increases the basic basal gastrin levels, basal acid output, and the peak acid output. So I'll touch briefly about how it increases these. No? So if we talk about the natural history of H. pylori infection, so H. pylori either it causes an acute gastritis, which lead to the development of chronic gastritis. Chronic gastritis are basically of two types. Either it is a pan gastritis, like it involves the whole of the stomach, or it is an enteral predominant gastritis. So if it is an enteral predominant gastritis, it leads to the destruction of the mucosa in the antrum, and the antral mucosa produces somatostatin, and due to the lack of somatostatin, there is increased gastrin and increased acid secretion, which leads to the formation of the duodenal ulcer. Whereas if there is a multifocal atrophic gastritis, it leads to the formation of gastric ulcer, and as the atrophic gastritis progress, it leads to the development of intestinal metaplasia, and the intestinal metaplasia can later develop into cancer, or if there is an increased in the lymphocytic proliferation due to the gastritis, it can ultimately lead to the lymphoma. So H. pylori infection can lead to an acute gastritis, chronic gastritis, duodenal or gastric ulcers, and also gastric cancer and lymphoma. By gastric cancer, I mean gastric adenocarcinoma. So now I will talk about the complications of the peptic ulcer disease. So when an ulcer is formed, the various complications which can occur are the bleeding, the perforation, or it can penetrate and lead to severe pain, or if a gastric ulcer heals, it heals with the fibrosis, which can lead to the formation of a stricture at the pylorus or in the D1 and can lead to the gastric outlet obstruction. So how to diagnose a peptic ulcer disease? So basically, on the basis of history, the symptoms are mainly non-specific. Patient complains of upper abdominal pain, and which, depending on the site, whether it is a gastric ulcer or a duodenal ulcer, it will either be aggravated by the meals or will be healed by, will be relieved by the meals. Okay, there are no specific examination findings for the PUD. So mainly the investigation of choice to diagnose an ulcer is basically the endoscopy. And radiology right now have a limited role. And on endoscopy, you just an ulcer is visible, and and that is how it is diagnosed. And if we want to find out the cause of the ulcer, that whether it is in malignant or it is a peptic ulcer only. So there are so the ulcers in the duodenal bulb, we usually don't need to biopsy the ulcer itself, because they are most likely peptic ulcers only. But in the but if there is the ulcer is gastric, then we may need to biopsy depending on the age and the clinical condition of the patient. And we must need to document the healing of the gastric ulcer by a repeat endoscopy. The other thing is that we need to do is the to find out the cause of the ulcer. For that, we need to test for H. pylori. So you must remember that the for testing for the H. pylori, we don't biopsy from the ulcer site. Okay, so because it is a, you may think that the H. pylori is present at the site of the ulcer, and we need to biopsy from the ulcer site, but we don't need to biopsy the ulcer per se. While at for any other ulcer, we would biopsy the ulcer site. So for example, to diagnose malignancy, or to diagnose an ulcer due to some infection like CMV or C. diff, because of C. difficile. And so we need to for or herpes virus, so for tuberculosis, for all these, or for say example like amoebic ulcers in the cecum or in the rectum. For all these, we need to biopsy the ulcer site. But for the gastric and duodenal ulcers, that is the peptic ulcers, we don't need to biopsy the ulcer site to confirm the diagnosis. In fact, we need to biopsy the sites other than the ulcer to test for the H. pylori. So what are these sites? Are basically uh, 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 basically the sites to biopsy for the H. pylori are, uh, we need to take biopsies from the multiple sites in the stomach. So we need to take from the lesser curve, we need to take the biopsy from the angularis, and from the greater curve, we take from in the antrum and from the body, both. So we need to take a minimum of biopsy from these three sites. So this is basically just an indication for endoscopy in the patients with dyspepsia. So basically, the patient who is coming in the clinic, he is just going to tell you the symptoms of upper abdominal pain, bloating, some nausea, sometimes vomiting. So these set of symptoms are known as the dyspeptic symptoms. So when to biopsy, the dyspeptic symptoms can be because of ulcer, and it can be in the patients without any findings in the endoscopy, and which we call as non-ulcer dyspepsia or functional dyspepsia. So if a patient comes to you with the symptoms of dyspepsia, so there are certain red flag signs, or during which you will if you find any of them, you will do an endoscopy. Otherwise, you can treat them without doing an endoscopy with the trial of the proton pump inhibitor. So if the patient is more than 50 years old, so and with a new onset dyspepsia, then you need to do an endoscopy. If patient has dysphagia or weight loss, or has an episode of GI bleed, or has failed at trial of empirical therapy, use NSAIDS or steroids, which are known to be as a risk factor for the formation of peptic ulcer, or they have signs of GI obstruction like early satiety, or recurrent vomitings, or the vomitings which contain stale food. The vomitings which contain stale food is a typical sign of gastric outlet obstruction. Or there is a genetic factor or a family history or an ethnic background which are associated with increased risk of upper GI malignancies. For example, the gastric cancer is very common in Japan. So if you have any such factors or a family history of gastric cancer, you would like to do an endoscopy. So I will tell a little bit about the diagnosis of H. pylori. It can either be diagnosed by invasive methods, that is by invasive I mean which require endoscopy, and it is basically histopathology, or it can be cultured, or a rapid urease test can be done. A rapid urease test is used very commonly in endoscopy everywhere, and it gives result in within 2-3 minutes. That is why it is very popular. You can advise the treatment to the patient in the same sitting when you do the endoscopy, whereas the biopsy reports would take 1 to 2 weeks to arrive. And the non-invasive method includes serology or urea breath test or stool antigen test. So a little bit about the rapid urease test. So the urea, so the H. pylori contains the urease, and which converts the ammonia which is present in the kit to the urea, and which leads to a change in the pH, and which produces the color change, and it takes around 2 minutes, and it is diagnosable uh, at the site in the endoscopy room itself, and patient can be advised treatment in the same sitting. So this test can be false negative with the recent use of PPI, antibiotics, or bismuth. So if the patient is on antibiotics or bismuth, we need to do this at least after 4 weeks of the stoppage of the antibiotics. And similarly, if the patient is on PPIs, they need to be stopped at least 7 days prior to doing the endoscopy. So I already told you about histopathology, that it is the gold standard for diagnosis. And to optimize the procedure, you need to take biopsies from at least these 3 sites. And then among the non-invasive methods, urea breath test is an interesting test, but it is basically usually not used much because it needs a radioisotope carbon-13 urea, which is not easily available. So the rationale is that the patient inhales the urea, which is tagged, radio labeled, and it is by the urease enzyme, which is present in the H. pylori. It converts into ammonia and the carbon dioxide, and the carbon dioxide is absorbed in the blood, and it is released in the breath. And because it is radio labeled, so it can be measured. And if the carbon dioxide is increased after the 2 hours of this test, after the 2 hours after the ingestion of the urea, the test is said to be positive and is diagnostic of the H. pylori infection. So now the other invasive test is the serology. Non-invasive test is the serology. So it is also useful and has a sensitivity and specificity of approximately 90%. But serology will be positive after eradication of H. pylori also. So it is not useful in establishing eradication of the infection. And it is not, and as far as the practicality and the practice is concerned, it is not commonly used. So I have never got done an H. pylori serology test even once. So just to summarize the test for the H. pylori, so it is basically the first is the rapid urease test. It is probably the most commonly used. It has a good sensitivity and specificity, but it requires endoscopy and biopsy. It can confirm eradication, and it is very fast. The results are available within 2 to 3 minutes. The histology, again, it is highly sensitive and specific. It can also confirm eradication, and it usually takes 7 days in our settings the reports to come. Culture is usually not performed, but if we have a patient who has refractory H. pylori infection, so to determine antibiotic susceptibility, we can order a culture. Serology is not used in the usual clinical practice. I have never ordered a serology for H. pylori even once for any patient, but it can diagnose the H. pylori infection, but it cannot differentiate between a new and an old infection, and cannot be used to document eradication, because it will still be positive if we give treatment and we want to document the eradication. We cannot. The urea breath test again has a good sensitivity and specificity and can be used to confirm eradication. And similarly, stool antigen test is a good test because it detects the H. pylori antigen in the stools. And although it is not easily available, so it is not available in our hospital, but it is available in private laboratories. Again, it is ordered very rarely if a patient is specifically does not want an endoscopy to be done, and he wants that some other modality, so we can order stool antigen test. So and it can also confirm eradication, because after a course of antibiotics, the antigens would not be detected. So now finally coming to the treatment of the peptic ulcer disease. So the aim of the treatment is to relieve the symptoms, heal the ulcer, prevent complications, and prevent recurrences. So to relieve symptoms and to heal the ulcers, for both the proton pump, for all these indications, in fact, to relieve the symptoms, to heal, to prevent complications, and to prevent the recurrences, we need to reduce the acid secretion. And proton pump inhibitors are the drugs of choice, because they are very effective in reducing the gastric acid secretion. They irreversibly bind to the canalicular membrane of the to the canalicular sites of the proton pump, and can lead to the cessation of acid secretion. So the other if we talk about the lifestyle modification, then they are to avoid NSAIDs and stop smoking. And so when the and the may and if you talk about the treatment, the drug treatment, so eradication of H. pylori if it is detected, and the anti-secretory drugs, they are the mainstay of treatment, as I told you, and proton pump inhibitors are the drug of choice at the present. And the other drugs like cytoprotective drugs like supralfate and bismuth, they are not used routinely for the patients with peptic ulcer. And besides, if you remember, both of those require acidic pH to form a coating in the stomach, and if we give them with PPI or the H2 blockers, the acid secretion is less, is stopped in fact with the PPIs, and the pH is not acidic, and both the supralfate and bismuth would not work. So for a model prescription, a gastric ulcer would be a tablet pantoprazole or any equivalent proton pump inhibitor in the PD dosage, 30 minutes before meals for 12 weeks. And a repeat upper GI endoscopy is recommended to document healing in the gastric ulcers. While for duodenal ulcer, the same treatment is prescribed for 8 weeks, and no need to document healing in cases of duodenal ulcer if patient is improved symptomatically. We need to add H. pylori treatment if it is positive for both gastric ulcer and duodenal ulcer. And I have not included the H. pylori treatment specifically in this lecture because it will increase, and there would probably a separate lecture for the H. pylori. And as far as the complications are concerned, they are either managed endoscopically or surgically. So we have a lecture on 28th about the endoscopy, the role of the upper GI and lower GI. So, that lecture has also to be taken by me. So I'll discuss briefly about the management of the peptic ulcer complications during that lecture, or what can be done endoscopically. So basically, as I told you, the hemorrhage, the complications are GI bleed. It can be controlled endoscopically. Rarely do patients require surgery these days for a GI bleed. The other is gastric outlet obstruction. It is also almost always managed endoscopically, and whereas the perforation and the penetrations are treated surgically. So from my this lecture, the take-home messages are that the peptic ulcer disease is a common disease, and the main etiological factor is H. pylori, and it is diagnosed by endoscopy, and you need to do a test for H. pylori. Treatment is basically proton pump inhibitors are the mainstay of treatment, and you need to eradicate H. pylori if it is detected, and most of the complications are managed endoscopically, and a few require surgery. Okay, thank you. So I think you can ask any questions if you have. So you have asked various questions like why there is different relation to food intake in gastric and duodenal ulcer. So basically, it is not actually very much classically described as we used to see. That is like probably the duodenal ulcer pain get relieved after after the gastric ulcer pain actually increases after the intake of food, and we used to feel that it is because of an increased secretion of gastric acid just after a meal, or increased secretion of gastric acid and pepsin. But how does that similar but why does this similar rationale doesn't hold for duodenal ulcer, which I don't practically know. But as far as this difference is concerned, it is an important difference. Important in the sense that it is clinically useful. Uh, that I can say from my own personal experience also. So sometimes you can diagnose patients specifically of duodenal ulcer just by taking history. This happens. This happens quite frequently. That you feel that after history that this patient has duodenal ulcer, and on endoscopy the patient has duodenal ulcer only. So I want to be. This is not a very much diagnostic for a gastric ulcer, but for duodenal ulcer it is actually helpful. You sometimes find it. You sometimes actually find this thing. Not very frequently, but sometimes, yes. So the three biopsy sites for the ulcers are to diagnose H. pylori are basically we need to H. pylori can either lead to an enteral predominant gastritis or it can lead to a multifocal gastritis. So we to increase our diagnostic yield, we need to maximize our areas of biopsy so that we can take a biopsy from the multiple sites. So one biopsy is taken from the incisura angularis. Basically, incisura is formed on the side of the lesser curve. So we can say that yes, on the side of the lesser curve, we are taking one from the incisura angularis, and one biopsy we need to take from the body, and one from the pylorus itself, pyloric channel, if you want to say, like from between the incisura angularis and the pyloric opening, the antrum or pyloric channel. So that we can take from the greater curve sites. Like we can take one biopsy from the body, and one from the intrum on the greater curve, and one from the incisura from the lesser curve, just to maximize our yield by including as many sites as possible. Any other questions? So I'm taking a lecture on this platform for the first time. So I'm like sorry for the disturbances which occurred initially. So okay, if there are no further questions, I would like to end the lecture. And so I'll be taking two more lectures for you this month. One would be the role of upper GI endoscopy and the role of lower GI endoscopy for the diagnosis and management of GI diseases, and one would be the role of ERCP and EUS. So both of them would be in the last week of August, probably on 28th and 31st. Okay, so goodbye then. Bye.